Alright, welcome back everybody. So last video we were almost done with reproductive physiology. So we discussed, the development, infant and child development. We talked about how this is mostly stuff you'll memorize by yourself. They have a couple things where they try to use all the same letters, so PSO, CRW, all of that stuff. And sure, that might help. But generally speaking, this is something that comes to you with time. And we talked about some of the hormones that are going to be very significant to pregnancy, right? Pregnancy is a really big deal. You get a lot of OBGYN type questions where the physiologic adaptations in pregnancy can often lead to certain pathologic outcomes, and you have to be ready for that, right? You have to be ready for that. And this table here from UWorld and this other table from whatever I Googled comes together to really help you figure out, what you can expect to see in a patient based off of the clinical physiologic change, right, and how it occurs, what mechanism leads to that. Now, some of these physiologic changes, they're great for the mother. The mother needs it, but it can lead to a pathologic issue, just like, for example, right, postpartum ovarian vein thrombosis. Generally speaking, this usually occurs on the right side. We talked about this way in the beginning when we started reproductive embryology, right? And this ovarian vein thrombosis, which can then go into the inferior vena cava, is due to the normal physiologic change of a prothrombotic state, right? A pregnant woman needs to be in a prothrombotic state because after delivery, she needs to be ready to not bleed to death, right? And way in the beginning, when we did actually anatomy right here, right, reproductive anatomy, we looked at the blood vessels and stuff, and we said how the ovarian vein and the testicular vein on the left side goes into the left renal vein, but on the right side it goes directly into the inferior vena cava, right? And over here I put that note, right, the ovarian vein thrombosis is more common on the right since the right ovarian vein drains directly into the inferior vena cava. And other than that, the other stuff was the Nutcracker syndrome and the May-Turner syndrome, which are just two more case scenarios that you want to make sure you understand. Now, the rest of physiology is just a couple more things that occur after pregnancy, and then we can jump into pathology. Thanks a lot, Milad. I really appreciate that, man. So now, here we are, up to lactation. Right? So lactation, after parturition and delivery of the placenta, a rapid decrease in progesterone disinhibits prolactin, right? So progesterone was inhibiting prolactin, right? Which makes sense because you can't be pro-gestation and pro-lactation at the same time, right? You should not necessarily be lactating if you're pregnant. So once progesterone disappears, prolactin starts to do its job, and that initiates lactation. Suckling is required to maintain milk production and ejection because increased nerve stimulation leads to more oxytocin and prolactin. Prolactin's job is to induce and maintain lactation and decrease reproductive function, which means that while you're lactating, again, the other way around too, while you're lactating, you cannot get pregnant again, all right? So there's a little period in between where a woman, generally speaking, will not be impregnable again. Oxytocin assists in milk letdown. It also promotes uterine contractions, and we use oxytocin ourselves as well. Oxytocin is a really big deal, and you have to remember throughout these videos lately we've been talking about those endocrine receptors from the end of endocrine physiology, and remember that oxytocin uses IP3. So breast milk is the ideal nutrition for infants under 6 months old, and this was a topic that we talked about a lot when we were in biochemistry, vitamins, right? Nutrition. Breast milk contains maternal immunoglobulins which confer passive immunity, mostly IgA, right? Secretory IgA for the entire gut lumen, the mouth, macrophages, lymphocytes. Breast milk reduces infant infections and is associated with decreased risk for child to develop asthma, allergies, diabetes, and obesity. Guidelines recommend exclusively breastfed infants to get vitamin D and possibly iron supplementation. Now, one important note they didn't really put here is that breast milk also doesn't contain vitamin K, right? And these are two things that we talked about in the nutrition section way in the beginning. So vitamin D and vitamin K are both given to an infant right after birth. Breastfeeding decreases maternal risk of breast and ovarian cancer and facilitates mother-child bonding. Right? So breastfeeding turns out to be great for both the mother and the child, right? For the mother, the chances of certain cancers are lower, and for the baby, immunity is better, right? So both of those things are really big deal. Now, again, reproductive and endocrine are kind of hand in hand. So let's go back and kind of look at the activity of prolactin here. Right? So you can see when we talked about prolactin, right here at the bottom, you have, right, pregnancy upregulates more estrogen production, right? And estrogen will upregulate the anterior pituitary to make more prolactin as well, right? However, right, at this point here, progesterone interferes with prolactin binding to the receptors on the alveolar cells within the breast, thereby directly suppressing milk production. Now, in First Aid 2018 and previous First Aids, they had that here. It was like there was a symbol like this showing you that progesterone is inhibiting the prolactin's action on milk production. But they took that away. I'm not necessarily sure if that was a mistake or why they don't have that here anymore. But always remember that, like, progesterone's job is to stop this activity. So while you're pregnant, you will not be lactating, and after delivery, you will be lactating. So I put some notes on that here too, and we talked about that a lot when we did our endocrine videos, because the endocrine chapter talks about all the hormones and, you know, endocrine functions except for reproductive hormones and reproductive endocrine functions. Right, so you got to make sure whenever you study reproductive, you have to revisit endocrine, make sure you understand the interplay of all the hormones with each other. Okay, very, very big deal. Prolactin was really a very important one to remember, because you also have to keep in mind the other little intricate interplay that test writers love testing you on is if a patient is hypothyroid, right, and they're making a lot of TRH. You can see there's a little green arrow here. Excess TRH also increases prolactin formation. Okay, so a man who is hypothyroid can also end up having hyperprolactinemia, which would obviously lead to breast becoming a little bigger in that man, and, you know, of course, prolactin has effects on libido and stuff, so you're going to see all of that in a man who is hypothyroid if they're not treating it. So Milad's asking if watching the psych videos are enough compared to also reading the 100 Cases of Conrad Fisher. The 100 Cases of Conrad Fisher are without a doubt very nice. I have not included those cases in this book because that's definitely something extra. So whether or not you need the Conrad Fisher videos, the Conrad Fisher 100 Cases is really dependent on, you know, how confident you feel. If you feel like you might need those 100 cases to better understand something, then without a doubt go for it. It doesn't really take up that much time. You can definitely go ahead and do it. You know, but watching the videos and doing UWorld is the first thing. Definitely do that first, you know, and then once you figure out where you're lacking, what you're having struggles with, keep revisiting first aid, and then you can keep going, and you can do the 100 cases if necessary. All right, so that's the whole lactation stuff with prolactin and progesterone and their interplay with each other. Let's see. Okay, then comes the topic of menopause, right? So menopause, you can get questions where they ask you what the hormonal changes are going to be, or what symptoms in a woman can be after menopause kicks in. So menopause is diagnosed by amenorrhea for 12 months, so basically no periods for a whole year. Okay, but generally speaking, if you haven't had your period for 4 to 5 months, you pretty much know you're most likely now going to be on menopause. There's going to be decreased estrogen production due to age-linked decline in the number of ovarian follicles. Average age at onset is 51 years, earlier in smokers, usually preceded by 4 to 5 years of abnormal menstrual cycles, which is why they say a whole 12 months, because you could have an abnormal menstrual cycle where you may have missed like 2 to 3 periods. You might have had 2 to 3 months with no menstruation, and then on the 4th month you got menstrual cycle again, right? So abnormal menstrual cycles can occur, but if you go a whole year, chances are you're pretty much done, and now you're on menopause. The source of estrogen, which is estrone, after menopause becomes peripheral conversion of androgens, right? So if you have too many androgens, that can lead to hirsutism. Right? So source of estrogen is now estrone. And we talked about the different estrogens earlier as well, so let me go back to that real quick because there's a little memorization tool there too. Estrogen, where was it? Not this far up, was it? Estrogen and progesterone we talked about together. Okay, Okay, right here. So you can see the potency, right? Estradiol is the most potent, then estrone, and estriol is the weakest. And you have to remember this order of weakness, right? Estriol is tri for 3, and the 3 means that the woman is pregnant. So it's the mother, father, and the baby, right? So estriol is the weakest in potency. Estrone is second, and then estradiol is the strongest, right? Being 2 is better than being 1, right? Estrone. All right, so that's the whole concept there. So you want to make sure you get that like power potency of those guys down correctly. Now, after menopause, right now you're basically just 1 in a sense because you cannot get pregnant again. Well, you can get pregnant if it's implanted into you, but you can naturally get pregnant again. So source of estrogen is now going to be estrone. Um, Elevated FSH is going to be the answer choice you're going to have to pick. Okay, elevated FSH is specific for menopause. Loss of negative feedback on FSH due to decreased estrogen. Right, estrogen goes back and inhibits more FSH secretion. So now that there's decreased estrogen, you're going to have really high FSH in a woman that's now in menopause, and that's how you can pretty much officially diagnose it, I guess. Right, so hormonal changes are summarized right here. Causes of menopause can be any of these. Oh, sorry. Causes. This is talking about what can occur in women who have now reached menopause. So what are things? What are symptoms you might see, which are totally normal to see in a woman who has menopause? Hot flashes, atrophy of the vagina, osteoporosis, coronary artery disease, and sleep disturbances. Now, the most common thing that women generally complain about are the hot flashes, right? They're going to just start overheating, really overheating, and this is very much affected. Each of these is affected by other things too. So some of these can be amplified by other symptoms that other scenarios that the woman might be involved in. For example, hot flashes are far worse in a woman who is obese. All right, atrophy of the vagina. That's probably the least complained about topic and least common one as well. Osteoporosis, again, if this lady had low vitamin D to begin with for a long time, or she has other bone related disorders, osteoporosis is going to be far worse. Coronary artery disease is going to be far worse in any woman who already has some kind of hyperlipidemia issues, right, or elevated cholesterol issues. And then sleep disturbances will be worse in a woman who might be stressed out and already has other kinds of neurological or psych disturbances, right? So each of these issues can be amplified based off of what other comorbidities a woman is suffering with. Menopause before age 40 suggests primary ovarian insufficiency, right? Premature ovarian failure. It may occur in women who have received chemotherapy and or radiation therapy. And this also can occur in anyone who's just really obese or smokes heavily, right? So menopause before age 40. On the left, I wrote cyclic and continuous use of oral contraceptive regimen are not associated with irregular menses or amenorrhea, and premenopausal patients who stop taking OCPs should expect spontaneous return of menses. Oral contraceptives may mask vasomotor symptoms that are typical of menopausal transition, such as the hypoestrogenic symptoms of hot flashes and vaginal dryness. This was the explanation to a URL question about a 50-year-old woman who took oral contraceptives for 17 years and stopped 3 months ago, but is now menstruating, is sexually active, and has vaginal dryness, but no pain or other issues. She had simply hit menopause, right? So that was a question that was trying to confuse you about what might be going on. This woman took oral contraceptives for a very long time, 17 years, but as soon as she stopped, her menstrual cycle should have resumed again, normally. But it didn't. So they were like, what could have gone wrong? And then they had answer choices to really trick you. Some of these answer choices were, she took oral contraceptives for too long, and now her menstruation is finished. And that's false. That has nothing to do with that. As soon as she stopped taking oral contraceptives, eventually her menstruation should have continued again. The only reason her menstruation didn't continue is because she was now menopausal. Right? And she is 50, so it's about time. Average age of onset is 51, so that's close enough. All right. So that's a very important thing you want to watch out for. Oral contraceptives are a very high yield topic. Now the other thing is, if these hot flashes, vaginal atrophy, any of these things become really problematic, you can start treating it, and we'll see some of these medications and stuff you can use. But generally speaking, most of these symptoms are occurring because of a lack of estrogen, right? So you can supply estrogen, however, it's very you have to be very careful with how you supply the estrogen, because estrogen can cause many problematic scenarios as well, right? And we just saw right here, how far up was it? Okay, so estrogen and progesterone. When we talked about these two hormones, we said, right, that estrogen can cause cholesterol hypersecretion, and progesterone can cause gallbladder hypomotility, right? So giving estrogen will increase the cholesterol hypersecretion in patients, and that's something that you definitely want to keep in mind as well, all right? But other than that, the other major issue estrogen can cause is endometrial hyperplasia, and that's something that can lead to endometrial cancer. So you have to be careful in how you help a patient with their hot flashes and other stuff. But the primary way of dealing with any of these issues is to, one, work out, maintain your fitness. It's one of the most important things all humans need to be doing. Maintain your fitness, don't become obese, eat well, and sleep well, and keep yourself calm. These are all like basic things that you have to do, which obviously no patient listens to, so you start giving them medications. Now, we talked about estrogen and progesterone a lot. Here is the conversation about the male hormones, or the dominantly male hormones, androgens: testosterone, dihydrotestosterone, and androstenedione. So just like estrone, estradiol, and estriol had potencies, there's potency here as well. DHT is the most potent, after which testosterone, and then androstenedione. Okay, so this is not too hard to remember. DHT and testosterone are up there, and you always remember them. Androstenedione is the last one. Right. DHT and testosterone come from the testes, whereas androstenedione comes from the adrenal glands. Now, what are the function of these guys? So testosterone, we saw earlier, right, is for the differentiation of the epididymis, vas deferens, and seminal vesicles, which are the internal male genitalia, except the prostate, right? The prostate does not come from the Wolffian duct. And then you have your growth spurt, right? Penis, seminal vesicles, sperm, muscle, red blood cells, deepening of the voice, closing of the epiphyseal plates via estrogen converted from testosterone, and libido. Now, this is another thing you can get basic questions on, so you got to be ready for that, right? After a certain time, a male cannot grow any taller because their epiphyseal plates have closed. And it closes because estrogen was converted from testosterone, right? So testosterone became estrogen, and then you closed it. It's a very important little thing to remember, that it's not the testosterone that directly closes epiphyseal plates. Estrogen closes it, right? But that estrogen came from testosterone. DHT, in the beginning, during early development, it allows for the differentiation of the penis, scrotum, and the prostate, right? And in the late phases, it causes other problematic things. It can cause prostatic growth, leading to benign prostatic hyperplasia. It causes male pattern balding, and it causes sebaceous gland activity. Of the three, the most significant is the prostate growth, right? Because you start giving medications to stop this. And the most notable medication that often gets tested is 5-alpha reductase, right? Testosterone is converted to DHT by 5-alpha reductase, which is inhibited by finasteride. And finasteride is a 5-alpha reductase inhibitor. So this medication is often tested. It might not be tested on your step 1 anymore, because newer research was able to show that finasteride was also leading to decreased libido and decreased erection, sexual dysfunction in many men. So many people had to discontinue taking finasteride, and if they wanted to continue taking it, they had to sign a disclaimer that they understand that this can permanently disable them from having sex. Okay, so it's a very problematic medication to take now. In the male, androgens are converted to estrogen by cytochrome P450 aromatase, right, primarily in adipose tissue and testes. Aromatase is the key enzyme in conversion of androgens to estrogen, right? And it's aromatase that allows your epiphyseal plates to close. Now, before we continue on, I just want to go back and look at one little thing from the beginning part. Yeah, right here. Right, so this table is very important, right? Your Wolffian duct gives you internal male genitalia thanks to testosterone. That's what we just talked about. And that includes all of these guys right here. But not the prostate. The prostate is an external male genitalia thing, right? It's under the same group of things, I guess. Even though it's not necessarily external, right? It's part of this portion here, right? So the prostate often is part of a weird type of question where, they might have a question about a male or a female who's developing too many extra things because of some kind of imbalance here, and then they'll list out what the things are. You have to make sure you remember that if the for example, let's say there's some weird question where a woman has male internals, right, genitalia, which is obviously very rare, doesn't really occur. But let's just say, something like that, and then they list out what the internal genitalia are. They should not have prostate listed there. That makes it the wrong answer choice, right? Prostate is part of the external male genitalia list. It's going to be the stuff that comes from dihydrotestosterone. Okay, it does not come from the prostate. Does not come from the Wolffian duct. So continuing on, what else do you need to know? So there's androgenic steroid abuse, right? Obviously, people, male and females, can use androgenic steroids to become stronger and gain mass for whatever purpose. Abuse of anabolic steroids to increase fat-free mass, muscle strength, and performance is pretty common, right, for people who are very athletic. Suspect in men who present with changes in behavior like aggression, acne, gynecomastia, small testes. And women may present with virilization, hirsutism, acne, breast atrophy, male pattern baldness, right? So why do these opposite effects occur, right? The man starts losing his testes, and the woman starts taking on symptoms of having excess testosterone, which makes sense for the woman part. So here, what you have to understand is exogenous testosterone actually inhibits the hypothalamic pituitary gonadal axis, right? Because now you have so much testosterone, so your hypothalamus is like, okay, we can chill out, we don't need to make more. And if you're not making enough, that leads to decreased testicular size, decreased sperm count, right? And then eventually the man can just have azoospermia, right? Cannot even make sperm. And that little HPA axis thing is, HPG axis thing is very sensitive, and it's very difficult to repair, right? Just because the patient stopped taking androgens does not mean that it'll pick back up and continue making all those androgens again. So definitely something you want to be very careful with. Not worth doing. Totally not worth doing. Androgenic steroid abuse is not worth doing, and most athletic events will probably disqualify you anyway if you do it, because there are tests to figure that out. At the bottom, I have an embossed note regarding aromatase deficiency, which is something we're going to see more of later, and we saw some of it earlier. All right, so we saw this earlier right here. Let me just come back to it. This image, right? Fetal placental aromatase deficiency. What occurs? If you have aromatase deficiency, right, then you can see right here, androstenedione becomes estrone, and testosterone also becomes estradiol thanks to aromatase. Right, and this is the placenta doing it. If you don't have aromatase, you're just going to keep all the testosterone you made. Testosterone is excess androgen, which causes both the pregnant mother to have virilization, so hirsutism, deepening of voice, etc., acne, and it can also cause virilization of a female fetus, if this is a female fetus. Right? So placental aromatase deficiency affects the mother and the baby, right? And here, if we're talking about just plain old aromatase deficiency, individuals with aromatase deficiency are unable to convert androgens to estrogens. Therefore, karyotypically female 46XX patients are born with ambiguous external genitalia and present with female pseudo-hermaphroditism because they have too much testosterone. Both males and females have normal internal genitalia. At time of puberty, females fail to develop secondary sexual characteristics and typically present with amenorrhea due to development of ovarian cysts that impair ovulation, as well as features of virilization due to increased testosterone, severe acne, and hirsutism. Mothers of affected children may develop similar features during pregnancy due to fetal androgen crossing the placenta. In addition to these abnormalities of sex development, females as well as males frequently have a tall stature due to the delayed fusion of the epiphyseal growth plates and signs of osteoporosis caused by estrogen deficiency. So now you can see, right, why some of these patients would be really, really tall. Their epiphyseal plate won't close because you did not convert the testosterone into estrogen using aromatase. If you don't have aromatase, you can expect the patient to be very tall. And that's a silly thing that you can get as an answer choice. It's also a silly thing that can just be in the question stem, and you might not think of it as such a big deal. But being tall is because you didn't close your epiphyseal plates at an early enough time, right? And at this time, the only thing you need to think of is you didn't convert testosterone into estrogen, which is a sign of aromatase deficiency. Now, the last page, Tanner stages of sexual development, right? This thing is very often tested. They'll just toss this into almost any question. NBME also likes this topic, right? They'll often have a question where a patient comes in with, you know, their child, mother bringing their son or daughter in, to tell you something doesn't look right, right? Because of course mothers are very concerned when their baby isn't growing the way they expect the baby to grow, or when their child isn't growing the way they expect their child to grow. So Tanner stage is assigned independently to genitalia, pubic hair, and breast, right? Three different standards basically. A person can have Tanner stage 2 genitalia, Tanner stage 3 pubic hair. Earliest detectable secondary sexual characteristic is breast bud development in girls and testicular enlargement in boys. And that's really easy to remember, right? Because that's the thing that's pretty much specifically unique to both genders. Breast bud for the girl and testicles for the boy. Super straightforward. So if you ever have a question on what the earliest detectable thing would be, you would just pick that organ. So you can see here they have like an entire breakdown of how they do it, right? Stage 1 to 5. Most of it, right, kicks in mainly at this stage right here, stage 4, right? So age 13 to 15 is when you start noticing that everything is growing just fine, right? But let's look at it one by one. So way in the beginning, around the pre-pubertal age, so puberty has not hit, there shouldn't really be any sexual hair, and there should be a very flat appearing chest with raised nipple in the female. Now, when you start hitting stage 2, now puberty is kind of starting to kick in, right? So pubic hair appears, and testicular enlargement occurs, and in the girl, breast bud is now going to form. That's the hierarchy, right? So the breast bud is now forming. That's 8 to about 11 years old. After age 11, now you're in stage 3. Coarsening of pubic hair, penis size and length starts to increase, testicles start getting bigger, and the breast enlarges and a mound forms. This is also going to be eventually leading to now the girl eventually will have her first menstrual cycle. Her first menstruation might occur near the end of stage 3. If menstruation has begun, you're usually around age 12 and above, so 13, 14. 14 is pretty late, 13 is like average. And that point, if the girl is already menstruating, at that point, she's now in stage 4, generally speaking, right? In stage 4, you can see everything is pretty much more mature looking, right? So coarse hair across the pubis, sparing the thigh, penis width and glans penis both increase in size, breast enlarges, raised areola, mound on mound, right? So everything's gotten more mature. And then stage 5 is after age 15, everything's good to go, right? There's not much left to develop here. After this is just going to become whatever it's supposed to be ultimately. Now these Tanner stage questions are almost always really annoying. They're very insignificant because there has to be a very big problem for you to really pick something's wrong, okay? So just because they tell you that a patient has a certain Tanner stage that looks like it's a little behind from age does not mean something pathologically is wrong, right? Everyone grows differently. Everyone grows at different size, different speed. People aren't all going to be the same, and there's no one standard for everyone to fit into. So unless there's a really, really big issue, nothing is pathologically wrong. So by really big, I mean something dramatic. Like, let's say you have someone who's age 14 and they're in stage 1. That's obviously really problematic, right? There must be some huge hormonal imbalance because that's very significant. But if you're on the border, if you read a question, it sounds very iffy. Something doesn't seem right, but at the same time, it still feels like everything's okay. Chances are everything is okay. On the left, I have a basic question. So this one says, a 7-year-old girl is brought to the physician by her mother for a well-child examination. The mother reports that she had her first menstrual period 1 week ago. See, now that is a huge sign, right? Knowing, I just said it right now, right, that if you just had your first menstrual period, you should be around age 13, right? And this girl is 7. So this is way too early for her first menstrual period. She has no history of serious illness, immunizations are up to date, physical exam shows Tanner stage 3 breast development, which fits, generally speaking, you could have your first menstrual cycle around this stage as well. Without treatment, this patient is at greatest risk for which of the following as an adult. So now, it's very obvious that she's definitely got precocious puberty. She started menstruating way too early, and her Tanner stage is also far above what her age should be, right? 7 is before prepubertal, but she's already over here. That's a huge, very significant thing. You see what I was talking about earlier? If it's not significant, you don't need to think too much and try to force yourself to pick an answer that's pathological. So here, there's definitely something pathological. And short stature was the correct answer because, again, they love picking on that, right? This is a fusion of testosterone and estrogen-related topic. In this woman, this little girl actually has excess estrogen. And estrogen is the one that closes epiphyseal plates. Okay, estrogen basically allows you or stops you from getting taller. So in this girl, right, being short is a huge and very likely scenario because she has high amounts of estrogen, right? Way too early, way too early. This patient has precocious puberty, a condition characterized by the development of secondary sexual characteristics before 8 years of age in girls and 9 years of age in boys. Patients with precocious puberty have an increased risk for short stature as an adult. Though increased levels of sex hormone initially causes accelerated growth, they also trigger early epiphyseal plate closure. As a result, patients have an increased height velocity but decreased adult height. Central precocious puberty is caused by increased gonadotropin-releasing hormone. This excess secretion is typically idiopathic but can be caused by several tumors, hamartomas, astrocytomas, pinealomas. Peripheral precocious puberty is caused by gonadotropin-releasing hormone independent exposure to sex hormones, which can be caused by granulosa cell tumors, Leydig cell tumors, congenital adrenal hyperplasia, and McCune-Albright syndrome. We saw McCune-Albright syndrome way in the beginning about chemistry. The other stuff that's listed here we're going to see soon enough, but this is a typical UWorld question where they actually showed you something was very much off. Now, if you ever get a question about Tanner stages that's not that far off, right? Maybe someone that's got stage 3 features and they're, 10 years old, that's not that bad. That's not that bad. They're only a year off, they're growing a little quicker. Nothing to be alarmed by, right? It's not like they're going to have some kind of alarming issue. So be very careful because they love throwing Tanner stage questions at you to really try to confuse you. But if it's not blatantly obvious that something's wrong, something's probably not wrong. Okay? The last thing here, again, related to the same topic, precocious puberty. So precocious puberty is appearance of secondary sexual characteristics like agenarche, thelarche, and menarche before age 8 years in girls and 9 years in boys, just like that question explained and showed. There's going to be high sex hormone exposure or production, leading to increased linear growth, which means that for her 8-year-old age or 7-year-old age, she might be taller than her classmates, right? She might be taller than her classmates right now, but by the time her classmates are 21, she's going to be the shortest of them all. Okay, so that's what you want to make sure you keep in mind. Somatic and skeletal maturation, and that maturation means premature closure of epiphyseal plates and short stature. That was the answer to that UWorld question. Types include central versus peripheral, and that was the stuff we just summarized in this explanation here. Okay. Now at the bottom is one extra topic I added in because UWorld had a question on it, and it's not in first aid. Right, so extra nipples, right, and they can follow along this line, as you can see here, accessory nipples, right, and this is called the mammillary line. So how can this occur? So this is how the question presented, and this is how you're supposed to know what to pick. UWorld said a 14-year-old girl is brought to the office for evaluation of a bump on her chest just below the right breast. The bump has been there for as long as she can remember, but it became a little larger 2 to 3 years ago. The bump also becomes tender just before she starts her menses. Both breasts and axillae appear normal, and exam shows Tanner stage 5 breasts, which is pretty normal. She's 14, right? There's a soft, raised, hyperpigmented 0.5 centimeter non-tender lesion inferior to the right breast. What is the cause of her presentation? So that lesion, the way they described it, seems like another nipple, right? During menstruation, during the onset of the menstrual cycle, in women, oftentimes breasts and the nipple tend to become much more sensitive and bigger. And in this woman, that's exactly what's happening. This 14-year-old girl, her extra nipple is also responding to the hormonal changes of menstruation. So the answer here was failed involution of the mammary ridge. The most common breast anomalies in women and men are accessory nipples, right? This can occur to a man as well. So this is called polythelia or supernumerary nipple. They are due to failure of involution of the mammary ridge. Accessory nipples are asymptomatic, but they may swell or become tender, similar to normal breast tissue, before or during menses, pregnancy, and lactation. Findings include epidermal thickening, hyperpigmentation, pilosebaceous structure of Montgomery areolar tubercles, smooth muscle bundles in the areola, and possible mammary gland and multiple ducts. Right, so it might even function like a normal nipple. It's not a problem. It could be aesthetically disturbing, but generally speaking, you don't really do anything about it. Okay, so there's no big deal. But it can be anywhere along the mammary ridge, so you want to make sure you understand that there's an involution that has to occur for that to not happen. All right. So that's it for that. In the next video, we'll finally delve into reproductive pathology and start seeing how all of that is supposed to present clinically as well as on your test.